Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is Pediatric Physical Assessment Part 2, which essentially deals with methodologies that you could employ when doing a physical assessment. The objectives for this session are to use a tool which I think is really effective called the Pediatric Assessment Triangle. You can also use a tool called Primary Assessment. You can also extend that to a tool for the secondary assessment, and then we'll just do some revision exercises just to reinforce all three concepts. When we do a general inspection using the Pediatric Assessment Triangle, this is where you get your first immediate impression. You don't touch the kid, whether it's an infant or a child or an adolescent. You just look at them. Inspection, which we said previously was 70% of physical assessment, and you listen. There's no touching, and this can take 20 to 30 seconds to give you an immediate impression. Is the kid good, bad, well, unwell, stable, unstable? Look, you can have a kid who has got diabetes mellitus and they have a problem with their disease or their illness. However, they look okay. And if they look okay, they're probably well despite the condition that they're in, which gives you more time to do what you have to do in order to get them some form of appropriate intervention. If they're unstable, unwell, look sick, code blue. Activate the emergency medical system. So, using the Pediatric Assessment Triangle is your first impression. Now, the Pediatric Assessment Triangle consists of A, B, C. Really simple. A is, what does the kid look like? B, do they look like they're having breathing difficulties or work of breathing? Nobody works at their breathing. Work of breathing means that you can see people breathing, and normally you can't see people breathing. You can't hear people breathing. Breathing is effortless, it's quiet, it doesn't require any use of accessory muscles. Then you've got C, which is circulation. Well, what's their colour, essentially, it's saying? Are they pale? Are they blue? Are they mottled? The Pediatric Assessment Triangle takes 20 to 30 seconds to implement to give you an impression as to whether they're stable, unstable, well, unwell, good, bad. Now, some of the Pediatric Assessment Triangle outcomes could be, for example, that, look, if they look good, if there's no work of breathing, if their circulation appears okay, they must be stable. Then you've got the right side to do with the appearance. This could deal with central nervous system issues, neurological, or metabolic issues. You've got the right side, which deals with work of breathing. This could be respiratory distress or respiratory failure. You can have a combination then with respiratory failure. Well, gee, if their work of breathing is bad, which means you can hear them breathing, you can see them breathing, they look dyspneic, tachypneic, they're hyperventilating, then they may appear bad. Their appearance may be affected as well. They may be cyanosed, they may be stressed, they may be anxious, etc. If you've got a combination of all three, appearance, work of breathing and circulation, they could be in cardiopulmonary failure. Code blue. Activate the emergency medical system. Start CPR. The Pediatric Assessment Triangle helps you determine how to intervene with certain outcomes. Then you've got shock. Well, in shock, their appearance, pale, cold, clammy. They have impaired mentation. They may be subconsciously affected. They may be consciously affected. So they could be unconscious. They could be semi-conscious. Their circulation could be affected as well. As we said, pale, cold, clammy skin, they may be hypotensive, and as a consequence of that may have impaired mentation. So the pediatric assessment triangle gives you an idea of what their situation is like very, very quickly, and determines very, very quickly whether they're stable or unstable. It's a very good, effective tool to use. A, B, C. Okay, let's review pediatric assessment triangle. Look at the infant. Inspection. Look at it in the context of appearance, breathing, circulation. Stable or unstable? Stable. Look at the image. All you can do is inspect. Look at it in the context of A, B, C. What do you see in 20 or 30 seconds? The child is sleeping. They appear to be cyanosed peripherally. Lips, hands, feet. This could be acrocyanosis, which is normal. However, in the context of looking at it, there could be respiratory distress, even though the child's sleeping. It could be respiratory failure, because you've got the appearance of being blue, cyanosed, and as a consequence of that, it could be related to breathing, which could mean the infant is then unstable. But it appears to be reasonably stable. Let's look at this infant. Appearance, work of breathing, circulation. Doesn't look happy. Peripherally and centrally cyanosed. We can just see inside the mouth a little bit. Probably unstable. Probably appearance and work of breathing indicate respiratory failure. Could be leading to a problem to do with the circulation, and could be a consequence of now cardiopulmonary failure. Our little girl coughing again. Appearance, work of breathing, circulation. All you've got is inspection. You've got 20 to 30 seconds to look how you can intervene and help her, if she requires help. Possibly respiratory distress, because you can see increased work of breathing. She's coughing, maybe she's gasping, maybe she's wheezing. All you can do is look and listen. In your situation now, all you can do is look. You've got another infant in the context of A, appearance, B, work of breathing, C, circulation. Any problems? Stable or unstable? Probably stable. Here's an infant. Appearance. I don't think he's sleeping. He looks lethargic, possibly moribund, maybe semi-conscious. Work of breathing we can't see, but this infant had sternal recession, rib recession, wheezing respirations, and circulation not very good either. Possibly respiratory failure, with appearance looking not very good, increased work of breathing. Could be in shock, circulation, grey, possible modelling. Doesn't look well. And if it doesn't look well, then it's probably unstable, which could be leading to a situation which involves cardiopulmonary failure. Appearance, work of breathing, circulation, 20 to 30 seconds. This little girl appears to be stable. Let's move on to primary assessment. Primary assessment is the first assessment after your general inspection, dealing with the pediatric assessment triangle. And this uses the ABCDE model: airway, breathing, circulation, disability, and exposure. Now, the airway assessment primarily deals with the upper airway. Is it patent? Is it not patent? Is the infant or child able to maintain their own airway? And the airway assessment is looking at whether the airway is patent. So you can be looking for chest or abdominal movement. You can be listening for air movement and breath sounds with auscultation. And then you decide whether it's clear or maintainable. And if it's not, you've got to assist them in some way. Then you've got the breathing assessment, which assesses the respiratory rate, effort, which is the work of breathing. Work of breathing essentially is, can you see the patient breathing, which means they must be using accessory muscles. Is their chest expanding? Do they have lung or airway sounds? What's their plethography or their oxygen saturation, their SpO2? Typical respiratory rates, if they are not distressed, in a neonate, which in this classification is newborn to 1 year, breathing is approximately 30 to 60 breaths per minute. In an infant, in this classification, is classed as 1 to 3 years of age, which is about 20 to 30 breaths per minute. A child in this classification is from 3 to 13 years of age, so their breathing rate would be approximately 10 to 20 breaths per minute. So airway and breathing concerns are primarily, you would find, increased respiratory effort. You might see intercostal or subcostal or sternal chest recessions. You might hear abnormal inspiratory sounds, such as stridor, snoring, or no sounds at all, which is offering your information such as complete obstruction. Management can be involved with lots of different ways, and primarily it's basic life support. It could involve the emergency medical system. It's important to let the child be in a position of comfort. They know how to look after themselves unless they are incredibly unstable. You might actually need to perform a head tilt chin lift manoeuvre to open the airway. You may have to provide back slaps or chest thrusts, or use airway adjuncts if you have access to them, or if you're an advanced healthcare provider, maybe advanced airway interventions. C is the circulation assessment, and this is where you're assessing the heart rate, the rhythm, pulses, peripheral and central, capillary refill time, skin colour, which involves temperature as well, their blood pressure, maybe their level of consciousness, and whether they're making any urine. Typical heart rates or pulses for the same classification that we had before: in a neonate, 100 to 160 beats per minute; in an infant, 80 to 120 beats per minute; In a child, 60 to 100 beats per minute. Typical blood pressures in a neonate are that they have a systolic blood pressure of greater than 60 millimeters of mercury. In an infant, a systolic blood pressure of greater than 70 millimeters of mercury. In a child, the formula is either 70 or 90 plus age times 2. I prefer the lower limit, makes me more aware of situations. So 70 plus age times 2. So if they're 5 years of age, then here you've got the 70 from my perspective. So age is 10, so their blood pressure should be at least 80 systolic. In an older child, same as an adult, the systolic should be greater than 90 millimeters of mercury. What are your circulatory concerns? Well, abnormal findings could deal with sunken eyes or fontanelles, depending on their age group. They may be crying with no tears. They may have an altered level of consciousness. They could be tachycardic, bradycardic, hopefully not asystolic. No heart rate. They could have weak central pulses and weak peripheral pulses. They could have decreased skin turgor. They could have an increased capillary refill time. The urine output might be low, which you can identify with dry nappies. And typically, infants or children should have a urine output of at least 0.5 to about 2 mils per kg per hour. Other abnormal findings might be they may have pallor, central, peripheral, which deals with the lips, mucous membranes, the conjunctiva even, their hands, their feet. Or, in more serious situations, mottling of the skin, which could be related to shock syndromes, or cyanosis, which could be central, the mucous membranes, the tongue, the conjunctiva, the lips, or it could be peripheral, such as the hands and feet. But always look at circulation in the context of their ambient temperatures, room temperatures, to make sure that they're not peripherally shut down as a consequence of being cold. Sunken fontanelles, reduced skin turgor, let's look at D now. D refers to neurological assessment, essentially. So, the D disability looks at mental status, cranial nerves, motor system, reflexes, the sensory system, coordination, how they walk. And the D allows you to rapidly assess their responsiveness, their level of consciousness, and their muscle tone and pupil responses. That's primarily what you're looking for. How alert are they? Do they respond to you? Are they flaccid or toned? Are their pupils reacting appropriately? Are they dilated? Are they constricted? Pupil responses. This little fella, very alert, very attentive, very focused. Inspection. Disability concerns deal with abnormal findings such as impaired mentation at a level of changes in their conscious state, headaches they may complain of, maybe blurred vision or appear fatigued, flaccid muscle tone. They may have a fever of unknown origin. Changes could be related to their balance or their coordination. They could have numbness or tingling in the limbs, which they can tell you about if they're old enough. There can be decreased movement in the limbs, they could have a tremor, they could even have seizures. A good tool that can be used could be AVPU. There are lots of other ones such as the Glasgow Coma Scale, Tickles. They're all acronyms to allow you to A, assess alertness. Is the patient awake? If they are awake, V, do they respond to verbal stimulation or talk to you? P, G, do they only respond to painful stimuli? Or U, is the patient completely unresponsive, unconscious? But there are lots of tools that can be used to assess their neurological state very, very, very quickly. Here's an example of a modified infant Glasgow Coma Scale, which assesses eye opening, motor response, and verbal responses. Then you've got exposure assessment. An exposure assessment basically means that you're looking at the whole body exposed. Well, again, don't promote hypothermia either. But this assesses the face, the head, the body as a whole, the skin, and the core body temperature. Exposure concerns deal with abnormal findings such as trauma, injuries, deformities. It could deal with hemorrhage or bleeding, bruises, which could be small petechiae or large purpura, which could occur in a number of different situations that deal with clotting anomalies related to certain infections. Could be related to rashes, which can occur as a result of infective processes or possibly allergies, and burns. This is exposure, and it provides additional information to your initial PAT assessment. So let's review and remember now. Look at the image. All you can do is inspect. You've got A, B, C, D, E. So in this situation, I don't think there are any concerns at all. Now you've got this little infant, which has got noisy breathing, sternal recession, impaired mentation. Their level of consciousness isn't fantastic. Are you concerned or not concerned? You're concerned. That's all you have to do. You identify whether you're concerned or not concerned because the infant is well or unwell, stable or unstable. Now you've got a child who appears to be having a seizure. Are you concerned or not concerned? Because if they're having a seizure, they won't be able to maintain their airway, they won't be breathing effectively, possibly their circulation could be affected, and this could result in possibly a neurological event. You're concerned. Now you've got the infant that's resting quietly, however, they're peripherally cyanosed and possibly centrally cyanosed as well. However, I don't know. I mean, I can't see the child here now. They may not be breathing at all. I'm not sure. They may be bradypneic. They may be hyperventilating. Am I concerned? Are you concerned? You're probably concerned. And you would do something about it. Whether it's basic life support, activating the emergency medical system, getting advanced healthcare provider support. Our little girl who's coughing, we're probably concerned. I mean, it may just be a cold, but when I look at her, she looks a little bit dishevelled, a little bit untidy, a little bit uncared for, eyes are a little bit droopy, mouth breathing, coughing. She doesn't look well. I would be concerned. Am I concerned about this little boy? Bruising to both eyes. I'm not sure why he has that. Is this probably a head injury of some kind? Possibly. You're concerned. Here we see an infant with abnormal lower limbs, a form of talipes. Are we concerned? Well, we may or may not be, but however, if we first saw this infant in our emergency department, we might activate someone with more expertise to come and look at the infant. So we would probably be concerned. Now, we're looking at this little boy in the context of airway breathing, circulation, disability and exposure. Are we concerned about him? Probably not. No concerns. Now let's move on to our final assessment, which is called the secondary assessment. And this uses sample as a focused history, which we've reviewed previously, and it uses a focused physical assessment. Here's our sample history, remembering that the sample history is one type of mnemonic acronym to assist you as a healthcare provider or professional to remember key questions to ask for a physical or a mental assessment. S, signs and symptoms, the chief complaint. A, allergies. Are they on medications? What's their past history? What was their last oral intake? And what were the events prior leading up to the chief complaint? Sample history. Now, the focused physical assessment, this focuses on the assessment techniques. And as we've already discussed, there are 4, but in order to do a focused physical assessment, you need to be able to use at least one of these techniques. And as I said, probably the one that I would employ to get my initial information would be inspection, because 70% of physical assessment is what you see, hear and smell. For example, if I observed the infant or the child pale, cold, clammy, I would suspect there would be a circulatory problem. So I would probably already know that when I take her blood pressure in my primary assessment, it's probably going to be low. If I feel her skin and her skin is cool and clammy, she probably will be hypotensive. She probably will be hypothermic. So, the focused physical assessment uses inspection, auscultation, percussion and palpation. In whatever order you choose, I would be recommending inspection, palpation, percussion and auscultation, unless you're doing an abdominal physical assessment. So in an abdominal physical assessment, you would typically do auscultation second, because percussion and palpation may interfere with whatever bowel sounds are present in the abdomen. And all these techniques, as I indicated previously here, should be used in a way that doesn't disturb the kid. It doesn't disturb the infant or the child. It should be used in a gentle, nice, organised way with parental supervision if possible. That way here you'll probably get the most accurate information. Physical assessment in pediatrics can sometimes be very challenging. Be kind. Be caring. An important component of a general physical assessment is vital signs. And most healthcare providers that I've come in contact in my career don't appreciate the importance of them. So let me be clear. Vital signs are performed to detect life-threatening problems early. So when you take their body temperature, you're taking that to determine hypothermia, normothermia, or hypothermia. Fever or no fever. When you take a pulse rate, you're taking a pulse or heart rate to determine normocardia, tachycardia, bradycardia, asystole. When you do a respiratory rate or a rate of ventilation, you're determining apnea, bradypnea, tachypnea. When you're looking at their respiratory rate, you're determining are they hyperventilating or hypoventilating. When you look at their blood pressure or record their blood pressure, you're looking for normotension, hypotension, or hypertension. And hypertension can be mild, moderate, severe, extreme. When you're looking at their oxygen saturations peripherally, SpO2, determined through pulse oximetry, you're looking for normal saturation, euoxia, hypoxia, and in some situations, hyperoxia. Then you're looking at pain assessment. Typically, we're pain-free, but sometimes we can have pain, which can be mild, moderate, or severe. All these vital signs can detect potentially life-threatening problems. So let's look at temperature. Temperature can be peripheral or it can be core. Core means internal. That's the more accurate one. And this can be taken either tympanically. Typically tympanically is the way it would be taken. Rectally is peripheral. Axillary is peripheral. Orally is peripheral. But the typical range is, as indicated, 36.5 to 37.2 Celsius or 97.8 to 99 degrees Fahrenheit. Temperature concerns are whether you're hypothermic or hypothermic. And if we took the common terminology with infants and children, we're talking about a fever. And a fever is typically classed as being 101.2 degrees Fahrenheit or 38.4 Celsius or possibly higher. Hypothermia in a child is below 95 degrees Fahrenheit to about 35 degrees centigrade. In an infant, it's a little bit higher, 36 degrees centigrade to 97 degrees Fahrenheit. They have a smaller body surface area, so they can become colder quicker. They're a concern because we don't want a febrile convulsion and we don't want them to become hypothermic either. Both are life-threatening situations. When we look at pulse rate or heart rate, we have essentially three types. Apical, which is taken typically in the fifth intercostal space in the midclavicular line, which we'll be looking at later when we do cardiac auscultation and assessment. Peripheral or central. Now the characteristics typically of a pulse are that it is strong, not too strong. We want it to be normal, not bounding. Regular, not irregular. Although in some infants and children, an irregular pulse can be normal. And this is typically associated with rhythms such as sinus arrhythmia, which is a normal rhythm in an infant or a child, sometimes an adult as well. But typically the pulse is graded at 3. Now, the rate of a pulse, typically, in this classification, infant, child, newborn. Newborn, 100 to 150. Infant, 80 to 120. Child, 60 to 100. same as an adult. Apical pulse, typically fifth intercostal space in the mid-clavicular line. What are some of the concerns? The concerns are you can have a weak pulse, a bounding pulse, a rapid pulse, or a slow pulse. And it can be irregular, but as I indicated, this could be a normal variant. It may not be, but it could be. Bradycardia, a concern. Tachycardia, a concern. Especially if the tachycardia isn't activated through sympathetic stimulation, such as running or exercise or some sort of activity. What are some of the rate warnings? Well, in a newborn, anything less than 100 is considered a bradycardia. Anything greater than 150 could be considered a tachycardia. In an infant, anything less than 80, a bradycardia. Anything greater than 120, a tachycardia. In a child, less than 60, bradycardia. Greater than 100, tachycardia. They could be concerns. Now let's look at respirations. Respirations, as we've indicated previously in the pediatric assessment triangle, are typically regular, quiet, effortless, no work of breathing, which means no use of accessory muscles. Breathing is typically unobservable. You don't see it. You don't hear it. You don't even have to think about it. Most of us are breathing and we don't even think about it. Rate of respirations, typically in a newborn, as we indicated in the pediatric assessment triangle and prior assessments, 30 to 40 for this classification. 20 to 40 in an infant, 15 to 30 in a child. Concerns of respiration deal with certain characteristics. So therefore, if the respirations are irregular with periods of apnea, this is a concern. Respirations are typically quiet, they're not noisy. There's no work of breathing, so there isn't any accessory muscle use. Other concerns could be thoracic recession, which could be sternal, suprasternal, substernal, intercostal. Abdominal breathing. The worst concern would be no breathing, apnea. What are some of the rate warnings? In a newborn, less than 30 or greater than 40 could be a concern. Certainly at rest. Certainly during sleep. In an infant, less than 20 or greater than 40. In a child, less than 15 or greater than 30. It depends. Everyone is an individual. But as a general rule, these would be concerns that you might have as warnings. When it comes to blood pressure, we're talking about the systemic blood pressure, the systemic arterial blood pressure. So the systolic in a child aged 1 to 10 years of age, the formula, as we indicated previously, 70 to 90 plus age times 2. So in a neonate or an infant, it should be greater than 60 to 70 millimeters of mercury. The diastolic, which typically isn't problematic in an infant or a child, but pediatric hypertension is increasing worldwide. Certainly in most Western industrialized countries. But the diastolic blood pressure in a 1 to 10 year old typically is 40 plus age times 2, and in a neonate or an infant greater than 40 to 50 millimeters of mercury. Make sure the cuff is appropriate size and placed correctly. Blood pressure concerns are hypotension and hypertension. So using the formulas that we've indicated previously, just increase or decrease. So the systolic arterial blood pressure in the child 1 to 10, less than 70 or greater than 90 plus age times 2. In a neonate, less than 60 or greater than 70. But remember, always look at it in the context of their physical assessment. If their blood pressure is in the lower limit of normal, are they cold, pale, clammy? Are they having signs of decreased tissue perfusion? In the diastolic, child 1 to 10 years of age, less than 40 or greater than 40 plus age times 2. Infant and neonate, less than 40, greater than 50. As a general rule. As a rule of thumb. When we come to oxygen saturation, we're talking about peripheral SpO2, and typically the normal range breathing room air at sea level is approximately 94 to 100%. Oxygen saturation's concerns are hypoxemia. And hypoxemia typically is classified in the range of less than 90%. And remember, this is a normal person. I mean, infants can have chronic lung disease for a variety of different reasons and have a saturation of less than 90, and this is still considered to be normal for their clinical condition. But typically, in a normal infant or child, the oxygen saturation concerns are less than 90 on room air at sea level, which is referred to as hypoxemia, low oxygen in the blood. No one has pain normally, unless they have a situation or a condition where they do have pain. It's a normal variant for them. But normally, we are all pain-free, and certainly infants and children. Although they can have growing pains related to muscular and bone development, but typically we are pain-free as infants and children, unless we have a problem. The pain assessment tools that we can use are numerous. You've got countless number of pain assessment tools. But pain is something that children do experience, and here in the United States, according to certain research processes, children, because they can talk, typically have headaches 20% in relation to pain. Abdominal pain 10 to 18%, limb pain 4 to 15%. And sometimes these are referred to as growing pains. They can also have chest pain, which is not indicated here. And chest pain is probably one of the most common reasons children go to an emergency department in the United States. And this can be related to not their heart, but sometimes related to esophageal spasm, which seems to be a common occurrence in pediatric patients that come to hospital. Some of the rating scales for pain are as follows, and there are more than these. A typical one could be the numerical pain scale, and this is for children who are relatively old and can communicate. They can say, oh look, I can look at the rating scale on a pain of 1 to 10, here 0 being no pain, 10 being the worst pain that I've ever experienced. My pain is, for example, 4, mild to moderate. Then there's the Wong-Baker Faces pain scale, and this is for children that are at least 3 to 4 years of age who can sort of identify with the faces. So a smiley face would be indicated as no pain, and an unhappy crying face could be indicated as the worst possible pain. And the child's face doesn't have to correlate with the picture. It's their subjective experience related to the pain that they're experiencing. Pain is subjective. People experience it in a different way, according to their culture, their socialization, their age. Then you've got F.L.A.C.C. F.L.A.C.C is to do with physical assessment, essentially. And this is now where you can observe face, legs, activity, cry and consolability. And typically this can be used on anybody, even adults. So this can be used for birth to 7 years of age or older, even older. So you look at their face. If you know someone's facial expression when they're having pain, then maybe if it looks upset, then maybe they're having pain. If they're moving their legs or not moving their legs, it depends. Because some people, infants or children, adults or otherwise, if they have a lot of pain, they may not move. If they have a lot of pain, they may move. What's their activity? Are they crying? Are they consolable? So these all provide information on a physical assessment basis for someone who can't communicate effectively. F.L.A.C. Then you've got C.R.I.E.S. C.R.I.E.S is another pain scale that typically is used for infants or up to 1 year of age. But you could use it on anybody. Here, are they crying? Do they require oxygen? Because their SpO2 is less than 95 or 94, as we indicated previously. Do they have increased vital signs? If you've got pain, typically your heart rate goes up. Typically your blood pressure goes up. Typically your respiratory rate goes up. May or may not increase your temperature. What's their expression? Are they sleeping? C.R.I.E.S. So now let's revise. Which of the following assessments would concern you and why? Most of this you're going to be using inspection. Okay, here's our little infant. Any concerns? I don't think so. Kid appears to be quite normal. Any concerns? Kid appears to be distressed. He's demonstrating what is called Levine's sign. Chest pain, heart pain. Probably a concern. Probably chest pain. But we could ask him. Baby comes into your emergency department, or you've been asked to look at this little baby. Appears to be underperfused, breathing difficulties, impaired mentation, maybe unwell, possibly unstable. There's probably a concern. It could be something related to perfusion. It could be related to something to do with respirations. There's certainly a patient assessment triangle or pediatric assessment triangle issue. Appearance, breathing, circulation. Are you concerned? I think so. The kid's having a seizure. There's an appearance problem. There would be a breathing problem. Respiratory muscles, diaphragm, intercostals are all contracted. Can't breathe. Are you concerned? I think you probably would be. Even if the infant was sleeping, they're blue. If they're blue, they could be hypoxic. And if they're hypoxic, this could be affecting their level of consciousness, their mentation. So they may not actually be sleeping, they may be unconscious. Are you concerned? I would be concerned. If she was my daughter, my niece, a friend's child, she appears to be unwell and she needs some sort of help. Am I concerned about this little boy? Sure. If I was told here now that he fell or he was abused in some way, I would be concerned. He appears to have a head injury, possibly. And this can result in other signs and symptoms or effects as a result of the injury. Epistaxis. Am I concerned? Depends on what he did, but probably. He would probably be concerned. He's got a nosebleed. Baby. I'm concerned. Got a huge hematoma there on his forehead, which is a head injury. I mean, their skull is very compliant. It's not as hard as yours and mine. Could have contusion, needs observation. Am I concerned about this little fellow? I don't think any of us are concerned about this little guy. He seems to be always in good spirits. He appears normal. So that's the end of part 2. So if you thought this was of any benefit to you, please participate and go and look for part 3, Pediatric Physical Assessment. And look, any of the other Dr. Manny Learn Shops that you might think might be relevant to your area or interest. Thanks again.